This assessment protocol is used with thanks to Dr. Robert Eccles, Doctor of Podiatric Medicine and Associate Professor of Biomechanics at the New York College of Podiatric Medicine. An accurate, rapid assessment of morphology can be done in 5 minutes or less without abandoning the idea of careful, methodical measurement and interpretation. This assessment protocol is not meant to totally summarise your options, but to help you get used to thinking about foot pathology and the quickest way to uncover it. If you're inexperienced with assessing feet, you need to make sure you are familiar with key bony landmarks. Take a look at the foot or a set of foot bones and identify the position of the head of the talus. When assessing feet for the first time, people often mistake the ankle joint for the talar head. The talar head is much narrower in shape and sits lower on the foot. Make sure you can identify the borders of the calcaneus. People often forget that the outline of the heel is not the same as the calcaneus and can be distracted by lumps and bumps on the heel when finding rear foot position. Finally, identify the position of each metatarsal head, paying particular attention to first, fourth and fifth. There are 4 things that need to be done during this period. 1. Look at the foot non-weight bearing. Find subtalar joint neutral and assess rear foot and forefoot position. Assess joint range of motion. 2. Ask the patient to stand in their normal angle and base of gait. 3. Ask the patient to rotate their hips while keeping their feet static. 4. Ask the patient to rise up on their toes. Observe from the posterior. Let's start with looking at the foot non-weight bearing. This is the foot in its uncompensated position. Assessing the foot non-weight bearing allows you to assess how the foot compensates when it is on the ground. Your patient should be lying prone on the treatment bed with their feet hanging over the edge. Step 1. Make sure your patient's leg is in the frontal plane. This ensures that the leg and foot are in a nice straight alignment and makes the assessment process easier. To do this, you can either move the leg into the frontal plane, place a wedge under the opposite hip, bend the knee of the opposite leg. Step 2. Put the foot into subtalar joint neutral. Hold the forefoot with your outside hand with your thumb on the 4th and 5th met heads. It is important that your thumb is on both the 4th and 5th met heads, as the 5th operates as a single unit, while 2, 3 and 4 work together. By having your thumb on the 4th and 5th met heads, you take 2 and 3 with them. Place the thumb and forefinger of your inside hand on either side of the talar head. Using your outside hand, gently supinate the foot as far as it will go. On most patients, you will feel the lateral side of the talar head as a distinct bump under your forefinger. Now gently pronate the foot as far as it will go. Remember that normal subtalar joint range of motion is 1/3 pronation, 2/3 supination, so the foot will not move as far in pronation. This means that the medial side of the talar head will not be as prominent and on some people will be quite hard to find. Continue to pronate and supinate the foot until the pressure under your thumb and forefinger feels the same. Then apply downward pressure on the 4th and 5th met heads until the foot is in a gentle 90 degrees. Leave your outside hand where it is and take the inside hand away. The foot is now in subtalar joint neutral with the mid-tarsal joint locked. Step 3. Assess rear foot position. Imagine a bisection line down the middle of the lower leg and another bisection line down the middle of the calcaneus. Use these imaginary lines to help you assess if the calcaneus is inverted or varus, everted or valgus, or perpendicular in relation to the lower leg. If there are lumps or bumps on your patient's heel, it is useful to use your inside hand to cup the borders of the calcaneus so these do not distract you. You also need to ignore the Achilles tendon, as this is normally attached more on the medial than the lateral side of the calcaneus, and so can throw out your assessment. Please remember, in subtalar joint neutral with the mid-tarsal joint locked, the rear foot is always in varus or at perpendicular unless your patient has a neurological condition or severe degenerative arthritis. So if you see a rear foot valgus, look again. Note down the patient's rear foot position. Step 4. Assess forefoot position. To assess forefoot position, you need to compare the plantar surface of the metatarsals with the plantar surface of the heel. The forefoot can be inverted or varus, everted or valgus, or parallel in relation to the plantar surface of the heel. While you are assessing forefoot position, it is important that you also check the position of the first ray. Is it in a straight line with the rest of the met heads, or in a dorsiflexed or plantarflexed position? If the first met head sits lower than the other 4, the first ray is in a plantarflexed position. The danger of not identifying a plantarflexed first ray is that it can make the forefoot look valgus or everted. As plantarflexed first rays can sometimes be difficult to spot, clues to help you identify this include pinch callousing or skin crease lines around the first met head, a gap where the second met head should be. This is not a gap, but simply that the first met head is so far forward it creates what looks like a gap. If the patient has a plantarflexed first ray, you will need to isolate the first met head and assess forefoot position based on the position of second, third, fourth and fifth met heads. Ask yourself, is the forefoot in varus or inverted, valgus or everted, or parallel in relation to the plantar surface of the heel? Note down the patient's forefoot and first ray position. Step 5. Assess joint range of motion. Start by assessing subtalar joint range of motion. This tells you about the amount of motion available at the rear foot. Cup the patient's heel with one hand. Invert and evert the heel. You are looking for 2/3 inversion, 1/3 eversion. Ask yourself, does the rear foot go through normal range of motion? Is the rear foot limited in inversion or eversion? Does it feel stiff? Decide if subtalar range of motion is limited, normal or mobile. Note down the patient's subtalar joint range of motion. Next, assess mid-tarsal joint range of motion. This tells you about the amount of motion available at the mid-foot. Hold the foot just above the met heads and hold the calcaneus firmly in its neutral position. Now put the midfoot through its full range of motion by inverting, everting, abducting, adducting, dorsiflexing and plantarflexing the midfoot. Ask yourself, does the midfoot feel stiff or flexible? Decide if mid-tarsal joint range of motion is limited, normal or mobile. Note down the patient's mid-tarsal joint range of motion. Finally, assess first ray range of motion. This tells you about the amount of motion available to the first ray at the propulsive phase of gait. Dorsiflex and plantarflex the first met head. There should be equal amounts of dorsiflexion and plantarflexion for normal range of motion. If your patient has a plantarflex first ray, he or she may be limited in plantarflexion, as the first ray is already as plantarflexed as it will go. Decide if first ray range of motion is normal, limited or mobile. Note down the patient's first ray range of motion. Assess the other foot using the same method. You now have a complete picture of your patient's feet in their uncompensated position. Now, ask your patient to stand in their normal angle and base of gait. The foot is now compensating for whatever distal or proximal forces are acting on it. Remember that the foot will do whatever it can to get all 5 meatheads on the ground, depending on the amount of joint range of motion available to it. Ask yourself, is the calcaneus perpendicular, inverted or everted? Has arch height changed significantly? Are you seeing in stance what you expected to see when the foot was non-weight bearing? Note down the patient's rear foot position on stance. Now ask the patient to rotate their hips while keeping their feet static. This allows you to see the available amount of pronation and supination, and verify what you saw in terms of joint range of motion when the patient was non-weight bearing. Observe and assess the change in arch height and change in rear foot and midfoot position. Now ask the patient to rise up onto their toes. Observe from the posterior. This tells you if the patient has the ability to supinate or resupinate during the late mid-stance phase of gait. Note down their ability to resupinate. Finally, have a look at the foot from the front and note down any other pertinent observations, including subtalar joint position on stance and bony changes. You have now completed the Eccles chairside assessment. You have gained a tremendous insight into the foot you are dealing with. You will be able to move into a more detailed exam or straight into treatment without getting sidetracked into areas which are not relevant to the symptoms which the patient presents with.